the Clinical Consultation Network. It's Tuesday at 12:30, so we do this every Tuesday at 12:30, and so I'm glad you could join us today. What else could we talk about besides COVID-19? I mean, this has been the topic of the, I guess, topic of the quarter, topic of the third of a year that we've been engaged in all this. And I guess the reason that we wanted to cover this topic again and kind of give a little bit of an update is because there have been several developments recently. We've had quite an increase in cases over the last couple of weeks. I'm going to show you some data that will indicate that, but just to give you a little bit of a flavor of it, since 2 weeks ago, so on July 2nd, among persons supported in our system, we had 72 people who were had tested positive for COVID-19. As of today, we have 107. So that's pretty close to a 50% increase in the number of cases that we've had just in the last 2 weeks. That warrants us really maybe thinking a little bit about how we're going to proceed, particularly as it relates to reopening. We had begun some reopening activities that perhaps is part of the reason that we're seeing the increase. You're also going to see through these data that I'm going to share that there's been an increase in testing as well. So, you are going to see more cases if you test more. There's no question about that. But as you test more people who are asymptomatic, you're going to see a smaller increase. The other thing that you're going to see in the general population is that there's been a decrease in deaths, the rate of death that is occurring with this increase in cases. And so we're going to explore some of the reasons for that. And I have as my co-host today, I have two co-hosts, David Taylor and Bill Feldhaus. Guys, you want to say hello, introduce yourselves to everybody?
Sure. Good afternoon, everybody. This is David Taylor. I'm the Director of Nursing. And sticking with the theme of previous CCNs, Dr. Davis, tell us an interesting fact about yourself.
Oh my gosh. I don't, some of the interesting facts are already known, I think, about me. I think I've already shared with people that when I was in college, I was a rodeo cowboy. I went to the College National Finals Rodeo in Bozeman, Montana. And I actually, in my junior year, came really close to winning the whole thing. But I choked on my last, in the steer, I was in the steer wrestling. And on my last steer, I choked, and I don't want to get too far inside rodeo here, but I broke the barrier. I fell off my horse, busted my knee, had to ride all the way back to Martin, Tennessee in the back of a Nissan Sentra. And by the time I got back, I was just about, my leg was, I was about ready to have it amputated. It was hurting so bad. So that is my little interesting fact.
What a great experience, though. That had to have been fantastic. Good memory.
It was fun, and I forget about it because I still have all the aches and pains.
Oh gosh.
But anyway, that'd be a little bit of an interesting fact. There are many more things I could share, but I won't go into all that today. Thank you for asking that.
Yep. Well, I was going to share one a little bit that a few of y'all know about, but some don't. I was adopted, and a couple of years ago, I did a ancestry DNA and found my biological father, and he lives in Atlanta, and I have two half brothers and a half sister, and they have multiple family all throughout the U.S., but primarily in Pennsylvania. They're in Georgia, and they had a family reunion and welcomed me to the family, and just turned out to be a really pretty amazing thing. That ancestry is remarkable. I would have never would have never imagined that in my whole life. It's always interesting though to see that. If I'm going to drag the ball over here to myself for a second, if I can, and I'll share
Yeah.
something. Um, let's see.
You got it. Yeah, there you go.
There you go. There is. I don't know if anybody that's on the WebEx should be able to see a picture, and so now I know who I look like. I have a couple of brothers that I favor a lot, and still you can still see the resemblance in my sister and my father, and
Yeah,
my wife said I have the same ears as everybody. So
man, that's cool.
that is my interesting fact for today. So
Well, that's great.
Bill, how are you?
Well, yeah, I'm Bill Feldhouse. I'm the assistant director of nursing, and you blended right into that picture. You look so natural. There's nothing interesting about me.
That's not true. You just don't want to share any of your secrets, Bill.
Well, we built our own house. I'll say that. I've got a 5,000 square foot house that we built. We subbed out the frame and anything brick related. But other than that, everything else we did ourselves.
Oh my God.
That's amazing.
I hung every sheet of drywall in this house by myself.
Wow.
I had a lift and scaffolding and got it all hung.
Did you get up on those stilts when you were doing that?
No, I just used a step ladder, and
Okay.
I had a small step ladder for the 8-foot ceilings, and then I had scaffolding on the 9-foot ceilings.
Well, Pam wants you to come to Memphis and do some work for her.
No.
Pam Gillespie.
I required surgery after that, so my wife.
I can understand that. Yeah.
That was my Mount Everest, because I set out. I said, I'm going to see if I can do this, and I did.
Well, that's
amazing.
That's pretty good. That's pretty good. I have to give you a lot of credit on that. All right. Well, that's a good little time of sharing there. I think we've got some interesting stories here in the clinical services division. So let's talk a little bit about these data. And this is going to be mostly for everybody out there. We're going to just kind of go through some of the data that we've collected. We've actually collected a ton more data than what we're going to show you today. Actually, we're still in the process of working our way through some of the information that we have, because we're really trying to understand this thing well. We want to help you understand it as best you can, so that you can make the best decisions about how you're going to support people with intellectual and developmental disabilities going forward. And so we're just gonna kind of freewheel through some of these data and have a little bit of discussion about each data point that we have. One of the things I'll point out here right on the get-go is that I've done some comparisons between the U.S. rates of infection, rates of confirmation, rates of testing, et cetera, and compared those to Tennessee's rates and compared those to DIDD and ECF rates. And so when we look at rates of infection here, we have, and so you're going to note that there is an increase in each of these categories, or many of these categories, and I'll make it clear as we go through them, that you're going to see an increase from one time period to the next. I mean, because the rates of infection don't ever go down. There are more people infected, so a greater percentage of the overall population is going to have had COVID-19. You would expect that under typical circumstances. What I'm contrasting here are the data between 2 weeks ago. Actually, I'm saying July 2nd. It should be June 30th here. That June 30th. Actually, no, I did calculate this from July 2nd. That was the last time we had a report of the data, and July 14th. And so you see that the U.S. rate was about 0.82%. This is of the overall population. and has increased now to a little bit more than 1%. The Tennessee rate was at 0.62%, has now gone up to, looks like close to 1%. The DIDD rate was 0.58%, now up to a little bit more than 0.8%. We're having a lower rate of infection than the rest of the population, it appears. So that's interesting. I'm just interested, David, Bill, what are your hypotheses about why you would see a lower rate of infection among people with IDD that are in our systems?
Well, based on an article I read a while back that compared some Pennsylvania rates and New York rates, I think we're doing exceptionally well with specific to the IDD population. And I think a lot of that has got to be given credit to the providers and the staff that have been keeping people at home and have been protecting everyone with PPE use when needed and things like that. It's that has been the main driver, I think, so far of why we have lower rates than some of the other states have experienced.
Yeah.
I agree. And I think also it's because we mobilized quickly. We saw what was happening in New York, got on top of it. The agencies got on top of it very quickly, and to be commended for that.
Yeah, I agree. I think we've had a great group of people out there working, and DSPs in particular been taking, actions to try to protect themselves, protect persons that they support. Those things are really, really important. And I think there is a feeling of responsibility. One of the things that Janet Schaus pointed out here just a moment ago, too, is that we tend to have lower, we don't have as large a settings as they do in some of these other places. So, and I was actually kind of shocked when some of the news came out of New York about the rate of death among people with IDD and the large congregate facilities that they still have in New York and New York City in particular, where there might be 40, 50, 60 people with IDD right in the same building. Most of our settings, even the ICF settings, are 8 persons or less, which does help you control the spread of this. And so I think that might also explain some of the reduction in the rates of infection. Do we have another comment there, Michelle? I might have, it came and went.
We had a few things that have been sent to me as well. Candy pointed out that there was an article in the LA Times about masks offering much more protection against coronavirus than many think. And then I had a question come in earlier that asked if you guys had heard anything or want to speak about research suggesting that type A blood seems to have more complications when COVID is contracted than type O. Is that anything you guys are able to speak on?
I can't speak on that. That's news to me.
Haven't looked at it.
Who has forwarded that question? Would they be willing to come on and talk a little bit about what they had found?
All I can tell you is their name is Mike.
Okay. Mike, if you want to unmute yourself Mike Milan. Okay.
Yeah.
Mike, why don't you come on and tell a little bit about what you've discovered, and we need to look into this. Okay. Well, Mike may not want to do that, but I do see a couple other people endorsing that. That's something we'll have to look into. I have to say I'm not familiar with that research, so we will have to.
Could you say that? Hey, Dr. Davis, could you say that research again? What was? I didn't hear what that was. This is Candy Turner. I didn't hear what you said that Mike had mentioned. Could you say it again?
Michelle,
they were suggesting
can you repeat it?
Yeah, there were research suggesting that type A blood seems to have more complications with COVID than type O, which seems less susceptible or have less severe cases.
Yes, I did have a article about that, or I haven't talked to Mike, so this has not been choreographed. Sorry, but I did happen to see some. I think it was a YouTube, and they were summarizing some research about that. O blood has a better has less a chance to get the virus. However, that doesn't mean O blood people need to be running around with, because you can still get it. But they also fare better when they get the virus. It seems that the research is pointing to that, and I can forward that. David? Would you like?
Yeah,
that'd be great.
Forward that to you. It's a.
Yeah, please
It looks
do.
like somebody shared a link in the chat box.
Okay.
This link for the WebMD link.
Good. Okay, so somebody will. But David, I'll send you what I have as well. Was sent to me by a family member, so of mine. So,
Thank you.
I think what it is, I don't really understand blood type very well, but it's like antigens are in your blood against, like if you have A blood, that means you have B antigens in your blood. And if you have B blood, you have A antigens in your blood. And if you have O blood, you have both A and B antigens. And there's a theory about response of that type of blood toward virus. And I'm not sure about it because I don't understand it. I talked to my son who's doing neuro research, and he was saying that yes, there's something about the body's response to the antigen, and it also may have, they're talking about a genetic link as well. And that may be part of what the O blood is too, is when you have an O blood expression in your genes, you've got some other genetic markers as well. So there's a lot of research going on about that, and I'm totally not the qualified one, but just have been seeing that out there. So interesting.
Well, that's excellent. I agree with you. I think we should be a little bit skeptical, but not too skeptical. We need to look at these things, and the part of what we're trying to do is put together a model for how you can predict who's going to do well and who's not. And especially as we try to individualize our approach to this, we want to make sure that we're taking all the variables into account that we can and coming
And
up with
I would also like to, I'm the one who shared about the mask wearing, and I just saw this advertised today. And one of the things they talked about is we've known for a while, and even learned in the 1917 pandemic, or I'm not sure, I've got the,
1918, yeah.
18. So the pandemic, and also they've done a lot of studies with mice about the load of virus that the person receives. Being indicative of how severe they will be, the sickness will be for them. And so the load of virus, you have to think about the mask. They talk about, while it may not protect you 100%, if you can block 75% of the virus you take in, then you certainly have a better chance to survive that load. So we have to think about this in terms of mitigation and trying to put every possible thing in our favor, and so just thinking about that and loads of virus, I hadn't even thought of that, so there's just so many thoughts
you might get a worse illness if you're not wearing a mask than if you are. Yeah,
and they talked about the reason it's different than the flu is because the flu, when you get the flu, you are most contagious the day after your symptoms arrive. But with this virus, you are most contagious apparently before your symptoms arrive. So that's why we really need to wear masks in the public, because you don't know that you're not spreading that virus. You're saying, well, I feel well, I feel fine, I have no problems, I'm not experiencing any symptoms, yet you may be having a huge load. They said the largest load of your viral spread is before the symptoms, and it lessens after the symptoms come on. You're
Yeah.
still contagious, but you're not as contagious. You know, and I think we've seen that, you know, a question, how can a family member be sick and quarantined in their home and not infect their whole family? And we've seen people do it. They've quarantined in their home with their family, and their rest of their family members don't get sick. And I think it's because of that viral load decreases once the symptoms appear. And that's
Yeah.
the theory. And but you know, it's well worth us considering that when we are thinking about how to support someone with disabilities through this pandemic.
And Candy, that would also include good social isolation in the home too.
Exactly.
I'm sure.
Exactly.
Yeah.
Absolutely. So we have to, you know, my husband and I both, I mean, I guess we're all thinking about how we're going to get through this. We've had to decide now what room are we going to use and how are we going to set this up and what bathrooms are we going to use. And
Right.
there's just a lot to think about how to, you know, I don't live in a sterile environment, don't live in a hospital, none of us do, but we have to think about how can we make it as close to that type of environment and the cleanliness and the hygiene of our home. You know, we have to think about that and get ready in case something were to happen. But anyway, I think all of that's going to be thought of, you know.
Yeah, thank you for that. That's so true. Everything that you said there, and you know, it's not. I go back. You know, when you think about this, it's not just the one thing, because no, a mask is not fully protective.
No,
but it is a lot better than nothing, and it also helps your fellow man because you're protecting them from what you're spreading as well. And
that's right.
since you may be asymptomatic, you may not know that you have it. And I don't know whether it is that people think that they have, you know, some kind of magical immunity to these things, whether or not that is, you know, what their you know, that they somehow are Superman, you know, that they can walk into this, or Superwoman, and they can walk into this without protecting themselves, without protecting. There's nothing positive about that.
Yeah, I think it's very difficult because it's something that we don't see, we don't understand.
Yeah.
And it's not, the transmission of this is so, there's such a lag time between the transmission and when you show symptoms. It's hard to believe that that's where it came from. It's hard to trace. It's hard for people to believe. And I think we also live in a world where we're unsure of information. It's hard to check out facts now because of the internet being so readily available, and it also being so susceptible to anybody putting anything out there, and we don't.
Yeah. There's a lot of misinformation.
Yeah, you got to know how to check that out. And I think our generation. I mean, I'm in my 50s, and I'm not even going to go there. But we were not taught necessarily how to check out facts. It's funny. My son will say, "Mom, you're so good at that." Well, I've just had to dig and think, well, this may not be true, and I've got to see. Do I have is there some type of research? And maybe I can't understand the research, but I can find a trusted person who can interpret that research for me.
Yeah. Well, and here's like one example of that I think is really relevant, because there's so much news out there. And so a news report will say, well, in X state, let's just put any state out there, there has been a record in the number of cases that have occurred, you know, nationwide, you know, so it's being proposed as if, well, this is the biggest increase that we've had, and in absolute numbers, perhaps it is. But what you have to consider is how large is the state, how, you know, what is the rate there? And these types of things, I think the news media is not always, they like to sort of prove their point a little bit with things and not give you the details about the data that they're reporting. And I think as good consumers of information, you have to look at those factors when you're consuming that information. So very good points about everything there, Candy. Really appreciate that. Now, when we look at here at the case break, yes.
Circling back to one question about our data, is our data being incorporated into the Department of Health's data?
Yes,
We are
or
reporting
that
that.
are reported. Any positive test, any test is reported to the Department of Health. Yes, we don't report it. It's reported at the by the lab that is conducting the testing, but the Department of Health receives all this information. And so everything that is in Tennessee's data, our data are part of that. So there is but we don't contribute very much to it because we're such a small population. So, so they're not completely independent here as data points in that regard. Is there another question? Any other questions, Michelle, before I launch into this?
There's been a lot of comments, so I'm filtering through. You can go ahead and I'll interrupt.
Yeah, just feel free to interrupt whenever. This is a freewheeling conversation we're having. So case rate, percentage of the total population that has had COVID-19. And so when we look at the United States, we've changed probably very little since July 2nd. We had an 8% rate, still got about an 8% rate. The rate in Tennessee has increased a little bit over that span of time. One of the things you'll note a little bit later is that Tennessee's done a lot more testing than a lot of other states. Our percentage of people who have been tested is greater. And so we have, it might be natural to expect that we're going to have a little bit higher rate of confirmation among people that we in Tennessee. And then we in DIDD, we have a really low rate of infection among our total population. And so this kind of just confirms what we were talking about before about all the good things that people are doing, wearing masks, washing hands, and doing the things that they need to do. But there's also some other factors that affect this, because when you have lower rates of confirmation, you have higher rates of testing. A lot of times you're going to see that we've tested a lot more people in DIPD than in other settings. David or Bill or anybody else, do you want to comment on these data?
Dr. Davis, just real quick, I wanted to say there weren't any additional questions, but there were a few recommendations in terms of maybe considering the demographic breakdown and looking at blood type when we're examining our data.
Yes, we will have to invoke that into our model. Okay, no other comments. We'll move on. Actually, this, I believe I have this mislabeled. It should be the percentage of the population, percentage of people who have been tested that tested positive. Why am I not moving? Next. There we go. And this helps you understand that a little bit better, because what we've had is a symptom exposure-based testing rate of 11.7%. So that means when you go based on the symptoms that someone is expressing, you get a much higher rate of confirmation, because the person is already showing signs that they may have it. So you're giving them test under that circumstance. When we did the mass testing that we did, look how much lower the rate is, 0.52% of the people that we tested through mass testing. So we identified 14 new cases for about 3,500 people that we tested with that. That's good that we had a really low rate there. But here's the other thing that it means, and this goes back to the point we were discussing earlier about asymptomatic cases, is that we only tested about a fourth of the population, and we found 14. That means that there are at least 42 other people out there, probably, if the rate holds through the rest of the population, that were unidentified as having COVID-19. And so herein lies the danger with all of this. David, Bill, comment? Yeah.
Question, this Candy. So the asymptomatic people, does anybody trace them to see if they then become symptomatic, or do they just stay asymptomatic, not only for this population that you know the people with IDD that we tested, but do
No,
y'all
they
know
didn't
that?
all stay asymptomatic. And in fact, we identified a couple of people that ended up dying as a result of COVID-19 through the testing. And they were asymptomatic at the time they were tested. And then within a short time after that, developed symptoms and died as a result of it. So, so there were people who were within a short period of time going to be symptomatic. But at the time they were tested, were asymptomatic.
And the only thing I can add to that is I just wanted to say thank you to all the regional staff and regional nurses that participated
Yes.
in our testing events so that we were able to test as many people as we did. That such a tremendous effort that y'all contributed to this, and we think it made a huge difference. Identifying 14 asymptomatic cases was huge in stopping outbreaks.
It was, and it also is huge in helping us kind of look at all of this and think about what do we need to do going forward. Without that testing, we would not be able to do that. And that shout out you're giving goes to all of the regional offices in this, all of the folks at agencies who took it upon themselves to do their own testing or to test even for other agencies.
Yes.
And to utilize their nursing staff in that manner. Our nursing staff just stepped up. And when we needed more information for this presentation today, just yesterday, our nursing staff stepped up and gathered a lot more information for us.
That was going to be my next comment, because I've been working with the regional directors and the nursing staff last week, gathering a lot of this data, and I appreciate their efforts to get all that.
This is a team effort, I'll tell you, all the way, and I really appreciate all the help that folks have given us in this. Let's see. So the testing rate. Now this is important to understand. You know, part of because we did all that mass testing, our testing rate is a lot higher than it is in Tennessee in general. We've done more testing than Tennessee, and Tennessee's done more testing than the United States in general. So we are leading in this area. Of course, these numbers also go up as we test more people. They're going to consistently go up. So you expect that increase that you see there between July 2nd and July 14th. Okay, now death rate among those who are presumed to have COVID-19. And I changed this because the definition here has changed. And as of June 12th, the Department of Health began including cases in their case rate or in the death rate for people who had symptoms that were consistent with COVID-19, rather than requiring to have a test that confirmed that. So this doesn't look right. Let me, that last slide, I'm going to say I need to go back and take a look at that, because that is not reflective of what is correct. I don't know if something there changed, because our rate is a lot lower in Tennessee than it has been, than it is in the rest of the United States. And part of that was because through June 12th, we had a little bit more conservative method of counting cases. Before June 12th, we only counted it as a death related to COVID-19 if the person had a positive test that went along with that. Since June 12th, we've expanded that. In DIDD, we're still counting based on whether the person has a positive test. So our numbers actually may be somewhat conservative, that we may have had people who died in our system who were not, did not have a positive test, but may have died from COVID. So when you look at this rate, 12,500, and I geared it toward 12,500 because that's how many we have in our system. We've had 6 deaths now, one more since July 2nd that have occurred in our population of 12,500. When you compile the United States data, the Tennessee data based on that same metric, you get in Tennessee, you can see a very low rate. Looks like I think it was about 1.25 per 12,500 people. When you look at the overall United States rate, it's higher, above 5% or 5 per 12,500 in population. So here's where we really want to have a little bit of discussion about why DIDD would be experiencing a higher rate. Now, part of what has to be taken into account, we have a lot smaller numbers. And so, one death makes a lot of difference within the numbers we're creating here. I want to acknowledge that right on the front end. But it actually follows a trend that I don't think is that far-fetched, which is that the people we serve are more vulnerable. I don't know, David. David, Bill?
Absolutely. The people that have died have had multiple health conditions, and can certainly fit into that typically older age group and complicating health conditions.
Yeah.
We did have a question asking about does this factor in people who've died for other reasons that just happen to test positive also? Is that still counted as a COVID death?
In our system, it is.
I don't know if we have I don't know if we have the ability to distinguish that as because they did, each of these people did have respiratory concerns that led to their death. So those would be presumed to have been caused by COVID-19.
Yeah, there were no deaths by accident for somebody that tested positive. It's not like they tested positive and then on the way home from the testing center had a wreck or something. They all follow the natural progression of a COVID death.
Like, really, that wouldn't be able to be verified without doing a full autopsy anyway, would it? There's not really a good way to sort that out.
Well,
if they had a proper test. I see what you're saying, though. Yeah.
Most of the things you would die from, the more common causes of death, respiratory failure, heart disease, things like that, you're probably going to think that may have had that the COVID had something to do with it in those circumstances. I'm trying to think of other circumstances where somebody, Bill brings the extreme example, somebody who dies in a car wreck on their way home. Well, that wasn't necessarily a COVID death. They might have survived. It might not have had any impact on it. I don't know what other conditions.
We haven't had any deaths like that. Ours all have been related to COVID symptoms.
Yeah, I think that all 6 of the individuals that have passed away from COVID, that we are counting as a COVID death, would still be alive today had they not contracted COVID.
Yeah, that's our presumption. Okay, let's move on. I've got a little bit of information here about the people who died. Now, I think this is an important thing to understand, and maybe that we want to talk about just a little bit. So we're talking about the number of people who have died from COVID-19 by level of functioning. So among the 6 who have died, 1 was in the mild range, 4 were in the severe range of intellectual disability, and 1 was in the profound range of intellectual disability. Let's do a little bit of quick brainstorming there, because whenever you start talking about data, things can go your hour can go pretty fast here. I'm already noticing that we've only got 15 minutes left. What are y'all's thoughts about why we might see this pattern?
I think in general, people with severe and profound intellectual disabilities have more illnesses. They have more problems to begin with. So
Right.
I think that becomes more susceptible. If you have COPD or you have a respiratory or chronic aspiration pneumonia and you get COVID, that's not good. And that's
Right.
what our severe profound people are most likely going to have.
Yeah, I'm going to show a graphic.
A very small sample here. So
Yeah, it is.
Yeah.
those should stay the same.
And I tried to trace this down a little bit too by looking at the data that the regional nurses were helping me gather this past week. We was on 90 of the people that have tested positive, and we're trying to focus in to see if there was anything that really sticks out in those groups of that. And I thought it was interesting. We've had 24 people with that have diagnosis with mild ID that have been positive, and 13 of those were recovering. 9 of them are asymptomatic but not have yet completely recovered. There were 2 that are hospitalized. 1 is recovering, 1's not doing well. In the moderate range, there was 21 people that have the diagnosis with moderate ID. 14 have recovered. 4 still have symptoms, and 3 remain hospitalized. In the severe group, we have 11 that tested positive, and this is not including the people that died. This data does not include the deaths. 8 have recovered. 1 has not recovered but still symptomatic, and we have 2 remaining in the hospital. 1 not doing so well, the other doing seeming to be recovering. And then the profound group, there was 22, 15 of which have recovered. 6 continue to have symptoms, and 1 has actually been transferred from a hospital to a rehab on a vent and O2. So and then there was 12 that the ID was not specified, and there was 11 of those people that were asymptomatic, and 1 that has not recovered but is asymptomatic. So it's just interesting because you really don't find any specific pinpoint there. It seems like kind of an fairly equal mix.
Well, there are a lot of people in the severe and profound range who have survived, and there were quite a few from West Tennessee in particular where they had a profound diagnosis and had survived. The question is, what other factors did they have? Was that the only factor we were dealing with? So were there younger people? These are factors we kind of need to dig into a little bit more. I do think that there may be some significance in this idea that the ones who did die, though, some of the ones who did die are in this severe to profound range of intellectual disabilities. Pam Wagner brought up communication as a factor. I think communication both ways. Person's ability to communicate what's going on with them, what their needs are in a given situation, what their health condition is, how they're doing with the COVID illness, and also their ability to follow instructions about caring for themselves and to understand what they're being asked about. These are all things that could increase a person's risk. Another factor that I didn't cover here, but that was present in at least 3 of these folks, they had diagnoses of impulse control disorder. Now, I have besmirched impulse control disorder as a diagnosis, especially in this group. Does maybe indicate sort of a factor, though, that for this folks in this at this level of intellectual disability that may be important, which is that if they are somewhat more impulsive, it might be more likely to get in someone's space if they're ambulatory and be close to others. We don't know if these had anything to do with the deaths or contracting COVID-19, but ultimately it is, I think, a group that is at greater risk as a result of that.
Possibly touching their face more.
You mentioned
not as amenable to hand washing and hand sanitizing. Could be
I would
Yeah.
think too, expanding on the communication barrier, they're not able to communicate those early symptoms of the virus, so it may not be noticed until it's in the more severe stages.
There you go. Very good. Very good. Yeah. This slide's about where the folks lived. Two were in medical residential, that you would think that that's probably a high risk population there. They certainly had a lot of co-occurring medical conditions, physical health conditions. Only one in ICF-IID, although I think when we dig a little bit deeper, we're probably going to find that there's a little bit higher rate of infection in ICF-IID. They tend to be larger settings, and so more chance of spread in those settings. I'm not certifying that piece of information. I'm only kind of, that's a little more of heuristic value at this point. And then the number of people who died from supported living was 3 here. So I haven't calculated these in terms of rates, I will say. So I'm going to qualify my data. That rate for supported living is probably a lot lower than the rates for these other two, because most of the people we serve are in supported living, and there are far more people in supported living than there are in ICF-IID. Probably about 7 times as many people in supported living as there are in ICF-IID. And I'm not sure how many we have in medical residential. Maybe David or Bill know, but it's not nearly.
Say probably less than 300 statewide.
Yeah. So if these were converted to rates, ICF-IID and medical residential would probably be much higher than supported living. Looking at physical health conditions, COPD, one of the things that the CDC has identified as a real risk condition. The one person with mild intellectual disability also had schizoaffective disorder and COPD. And I thought about that a little bit, because people with psychotic disorders do tend to smoke more, and I'm not 100% sure if that person smoked or not, but this is a factor that needs to be looked into. People who smoke are at greater risk under this scenario as well. So that was a huge risk factor in these data. The latest person that died also had COPD. Diabetes mellitus was 2 of the folks in this sample had diabetes mellitus 2, type 2 diabetes. The heart disease was present in one person, kidney disease in another person, obesity, and one person had no serious chronic conditions. It was a person in the severe range of intellectual disability, and I cannot remember the age of that person. It may have been the 59-year-old. I'm not 100% sure. And you will see that there is more than 6 conditions listed here. That's because some people had multiple conditions. Average age, though. Now here's a big factor to look at, and that is there were, as average age of those who died was 66 point something. You can see it's where that is. And then the average age of survivors was 42.89 years. So quite a significant difference in age among those two groups. Candy asked the question, why is age playing such a role in this? I just think that your physical, first of all, I want to be careful. I'm not saying that it causes you to get the disease more readily. I just think that your physical health has declined. So, even under the best of conditions, your physical health declines over the course of time. You're more susceptible to different sorts of illnesses. You probably have more chronic health conditions. When you get right down to it, that's probably a lot of the picture. I don't know, David, Bill, comments?
I think you're right on the money. I mean, sorry, my microphone isn't going. But I think you're right on track.
You presented actually better data than I have here, because I was still missing quite a few people, but I'm not sure if this held, but repeat your numbers that you had for level of functioning among those who survived. or were surviving.
Give me a second to pull it back up. Well, I can tell you I'm having trouble finding it now. Because I had closed it after I went over it. But we have had at least 61 people recover. So that leaves us with about 46 people right now in the recovery process. And there are 8 people hospitalized, I believe. And so, I mean, I'm thinking we're even making good progress with those that have, of the 107 that we know have tested positive. We're on the road to getting, for those folks to be recovered.
Yeah. I'm very hopeful for that. I'm always worried about people who go in the hospital, and it's certainly a place you get the care that you need. And so we want to make sure people have that, but we also, that's, it's not always a great place to be, to inure toward your survival in those circumstances. So, I think it's we want to try to keep people out of the hospital unless we have to. Just a few trends here, though, in the data. So we look at people with severe to profound disabilities being more prone to die from COVID-19. I want to look at that a little bit further, but I do think that there is something there that we need to be concerned about, we need to be thinking about. And as we're putting together a model for understanding susceptibility to death or severe symptoms, that's one of the factors we should be taking into account. Now, it's probably somewhat correlation versus causation in this circumstance, but it is a group that I think we need to be looking at. The age range. Yes.
We had a question. Are we doing anything to track the health of recovered patients just due to their being at higher risk with the damage caused to their heart, lungs, brain, et cetera?
Yes, that was part of the data request from the regional nurses. I wanted an update on the individuals. If there had been have they returned to a baseline functioning prior to testing positive for COVID-19, or have there been, do they now require additional care or assistance, or, that type of thing? We have not several, we have 3 or 4. I did pull that data back up. Let's see, I'm going to go back to the grouping again, so I broke it down. In the profound group, we have 1 that remains on oxygen that has recovered. In the severe group, we have 1 that remains on oxygen and a tube feeding. In the moderate group, it looks like there's no significant ill effects from COVID-19, or in the mild group, it looks like everyone has recovered. That has recovered well. We still have a couple of people with mild ID that are hospitalized.
So, well, and they're still in the midst of their period of recovery. And one of the interesting things here is the word recovered, when it's used for data collection purposes, means that you're no longer infectious. Essentially, that you've passed that period of being infectious and now are no longer infectious, but it doesn't mean you're not still experiencing some of the ill effects from having had COVID-19. What you just reported supports this idea that people in severe and profound range are even more are susceptible to those severe symptoms on an ongoing basis, severe outcomes from COVID-19. So I think it's a huge factor to watch. The age range of those who died, 59 to 73. Survivors were about 43 years old. So the idea here, I think that there should be I'm going to talk about this on the next slide, but there should be a little bit different way to look at the age factor. Chronic underlying medical conditions do increase the probability of death. And so there is a list of those on the CDC website. We've talked about three of the major ones: COPD, diabetes, type 2 diabetes, and heart disease being three of the real severe circumstances under which a person may experience worse outcomes from COVID-19. So a few things here, ideas moving forward, and I'm going to cover these quickly because I ran out of time again here, David and Bill. But staff testing, we're working on with the Department of Health to establish some parameters and logistics of that. It looks like it's probably going to be the agencies out there are going to have access to be able to get self-administered tests for staff and to be able to submit those and get results. We haven't determined the exact frequency with which that testing should occur, and we're working hard with the Department of Health to get those things nailed down so that we can get a staff testing program up and running within our community agencies, in our public ICFs, private ICFs. Visitation policies. I think there need to be a lot of considerations with respect to visitation. I thought I had a slide in here, but our rate of increase is higher than 10 cases per day right now. The Department of Health recommends that any county, nursing homes.
That's statewide, Dr. Davis, correct?
That's statewide, yes. So that's across our entire system. And if I were to take individual groups, I'd probably find even higher rate of infection, although rates of infection are equivalent to having severe. But the rate that we have is about double that 10 cases per day for 100,000 people. If you have a nursing home in a county where there are more than 10 cases per day for 100,000 people, you're to really strongly consider visitation, limiting visitation in a pretty extreme way. And so that has that would apply to our population in general. You might want to be thinking about people who are really vulnerable in particular, though, with regard to visitation, and working with your families to try to establish something that's safe for people under these circumstances. I mean, we want to be safe with everybody, but we want to be particularly safe in homes where there are people who may be in the severe to profound range of disability, over age 55. So I'm saying 55 rather than 65 for our population. And that's because first of all, they don't tend to have as high their lifespan is not as long. So typically a person with disability lives about 6 years less than a typical person. So that's one reason that rate, that age should be lower. And also, if they have any of these other things that are going on, that's very likely to put them in a very vulnerable position. And then, of course, we've talked extensively about premorbid chronic health conditions, and really that's probably the king of everything when you get right down to as far as risk level. So visitation may be something that agencies need to be thinking about right now. Staffing, also more vulnerable people need to limit exposure to others, so you need to have lower numbers of staff out there for people who have had these vulnerabilities. And I coined a little bit of a phrase here called the skills of engagement. The skills of engagement being those things that you need to be able to do pretty well in order to be engaged in a lot of social activity right now. And these things, if we had done these things from the very outset, we might, when we say lock everything down, that's because we don't know any better ways to be able to control it than to lock it down. We do know some ways that we can reduce the risk, and each one of these things builds on one another. If I do hand washing, that's great. If I also do distancing and I do mask wearing, and I choose carefully the places I go, all of those things, then there are ways to make things safer. And we need to be working really hard with the folks we support to teach them these things. Don't just assume you can't teach them. how to do it. These are important things to be considering. And then, yeah.
I'm sorry, can you touch on one thing real quick?
Yeah,
It'd be individuals going out with family for a weekend and returning.
Oh, yeah. You want to go ahead and talk about that, or?
I was just going to say each agency needs to develop a policy on that themselves, based on your needs. But I mean, if you think about it, a person going to visit their family over the weekend really is not much different than a staff member going home to their family at night and coming back to work the next day.
Yeah.
So just because someone goes to stay with their family over the weekend doesn't necessarily mean that they need to be tested when they come back. Have they had a direct contact exposure with someone? Are they presenting any symptoms? Those are the kind of things you need to be looking at, rather than just automatically thinking that everyone needs to be tested if they leave the home and return. That's not the reality with staff. I know there are some agencies that have when there's specifically an individual with COVID-19, they have minimized staff to the home and actually had staff staying in the home 24 hours. What a great thing. I know it's a lot of on staff to do that, and it's a lot on the agencies to pay for that to be done. But that is a tremendous thing, and we've seen that at several agencies. But yeah, as far as the just like visitation, you got to think about what's the risk. And we've had some that have visited, but have visited outside. So anything like that you can do like that to decrease a risk is the way to go with it.
Yeah, visiting outside. I'm glad you brought that up. And the last thing I'm going to cover here is ideas is benefit risk analysis. Do a general benefit risk analysis of your settings. Use those factors, those vulnerability factors that we were talking about in doing that benefit risk analysis and determining what your strategies need to be going forward. And so the more vulnerable, the more conservative your approach probably needs to be under these circumstances. And then if you're doing outings, to do that same benefit risk analysis for each outing that you're going to. So what are the circumstances where we're going to be out? Are we going to be in a crowded place where it's going to be more difficult to distance? And can this person that we're asking to go out now or encouraging to go out, can they wear a mask? These are all different things I think to be thinking about. There's a question here about masks and face shields. Those two in combination are actually a pretty good protection, but you don't want to do one. You don't want to just do a face shield. Face shields alone will not provide you the protection that you need under that circumstance, although either one is better than nothing. Each of these things just has a little bit of a protective factor. None of them are perfect. So you want to have every layer of protection that you can in these circumstances. And I apologize that we have gone over the time frame for today. It's all David and Bill's fault.
It's just such an important topic right now.
It is, and I think there's so much to discuss here, and so much that we need to yet learn about COVID-19. And actually, one of the things I hope to do is go back and investigate some of the things that people brought to our attention about blood type and its impact on potential vulnerability. And so we will be updating this as time goes by and adding to our knowledge and information about it. I'm going to correct a couple things in this PowerPoint, and then I'll send it out to people so that you'll have these data for your future reference. And as always, we appreciate you being here with us on the Clinical Consultation Network, which we do every Tuesday at 12:30. Appreciate you being here, and we will see you again next week.
Have a good